Colleagues and guests, the Cortelyou-Lowery Award is given annually to an outstanding faculty colleague who has demonstrated sustained excellence in college and university affairs. In his 16 years as a tenured line member, the last 9 of them at DePaul, Professor Fernando De Maio has demonstrated extraordinary commitment as a scholar, a teacher, and an administrator. It is our honor to recognize him as the recipient of the 2020 Cortelyou-Lowery Award. Born in Buenos Aires, Argentina, Fernando earned his doctorate in the UK at the University of Essex in 2005. After teaching for several years in the Department of Sociology and Anthropology and the Latin American Studies program in Simon Fraser University, he joined the DePaul Sociology Department in 2011 and was quickly tenured and promoted to associate professor in 2013. Fernando has taught a range of courses in his area of specialization, medical sociology, which include the structural and social determinants of health and the health effects of income inequality, immigration, and racism. He has also made significant contributions to instruction in the Masters of Public Health program, particularly in the development of the new social epidemiology concentration. He joined the rank of full-time professors at DePaul in 2019. During his time at DePaul, Fernando has contributed significantly at all levels of service, directing both the undergraduate and graduate programs in sociology for full terms, and serving by dean's appointment on the College Research Committee and by election to the College Committee on Curriculum and Programs. Dear colleagues and guests, without further ado, please help me welcome Fernando De Maio.
Thank you so much, Guillermo. That's a wonderful introduction. And it really is overwhelming to see all these fantastic names and faces on Zoom. It's a rare chance where different parts of my world collide. And I really want to thank you all for being here today. And really, I am so grateful for this award. I hope you all know how grateful I am to be part of the DePaul community and what this university means to me. I've gotten to know many of you in the past 10 years. I've learned a lot from you. And it's not often that I get to pause to reflect and really say thanks for that. Especially at this time, right, in the middle of a pandemic, which has had devastating effects on the health of people around the world. I am grateful to be a professor at a social justice institution. I have the rare opportunity to get to think and write and talk about big questions of inequality and social justice, using research and data in practical ways to support the causes that I believe in. Before I go further in the talk, though, I want to acknowledge the presence of my daughter, Lucy, who's tuned in. My daughter, Joy, chose to watch Fuller House instead of listen to this lecture, which I understand. But I'm humbled and grateful to see the presence of fantastic colleagues from different spheres of my life, including 2 former PhD supervisors, Tim Dow and David Pevlin, who I'm very grateful that you're here. Last but not least, I also want to acknowledge my new colleagues at the American Medical Association, many of whom have tuned in. Thank you for the welcome you've given me at the AMA Center for Health Equity, and I can't wait to continue our work together. In terms of organization, my good friend David Ansel at Rush University Medical Center taught me to organize a talk into 3 parts. Because, well, if you don't like one part, the next part comes pretty soon, and then by the end, you're near the end. So it seems to be pretty good for the audience. And the 3 parts roughly mirror the interview format we have used in the Center for Community Health Equity in our Voices of Health Equity interviews, a rare qualitative project of mine, where a group of us, including some fantastic graduate students from the MPH program, have interviewed clinicians, researchers, and community activists building up an archive of public-facing transcripts, essentially asking, who are you? How did you get to be who you are? What do you do? And what do you see ahead in this field? In our case, what do you see in the future of health equity in Chicago? So I like to borrow that format, and so have 3 parts to offer you today. Part 1 will be a short biographical sketch. I'll go through that fairly quickly, and I hope you'll forgive any moments of nostalgia. But I think it's useful to pause and consider and name some of the people who have helped me along the way. I have been remarkably lucky to have mentors and colleagues at critical junctures in my career, and it's clear to me that I would not be here if it were not for them. I've had so many opportunities to try new things, to develop and grow, and I'd like to signal some of those moments for you in my talk today. Part 2 will be the work. I don't think I can give a talk without showing a scatter plot or regression model of some kind. So rest assured there will be some data, but no math, and you won't have to work through any formulas. So rest assured. Part 3 will be some lessons learned. To be sure, I don't have things necessarily figured out. As we say, this is all a work in progress. But I think over time I've come to identify a few broad principles that I think are worth our time to consider and may resonate with your work as well. So I'll start my story at the University of Toronto in Introduction to Sociology. Like many of our students today, I didn't know what sociology was back then. I had enrolled as a political science and economics double major. Political science because I had the notion that I was interested in political issues, and economics because I wanted a safety plan. And I thought that if anything, I could get a job at a bank with a degree in economics, so it seemed like a safe bet. So it's 1995, and I'm sitting near the back in a 300-seat lecture hall, trying to make sense of what this will be like. And I really do try to remember this often. At one point in my life, I didn't know what office hours were. I didn't know about research. I didn't know about journals. I didn't know how to be in an academic setting. And of course, many of our students show up at our doors like that every year, right? Not knowing what this will be like. The professor was John Allen Lee. And there's a lot that I could tell you about John Lee if we had more time. He was a remarkable person and truly one of the great mentors in my life. But in the interest of time, I'll reflect on just one experience that frankly says more about John than it does me. It was the first week of class, and he offered us a choice. Bless you. You can do this course as specified in the syllabus, or you'll write the 3 tests, the multiple choice questions, etc., the final exam, or you can do an independent project. I'll guide you, but you have to figure out what to do. He even said you don't even have to attend class if you don't want to, and you don't even have to write the final exam. I didn't know any of this at the time, but John Lee was informed by Carl Rogers in the Freedom to Learn philosophy, and he actively tried to push the boundaries of what a university education could be, challenging power relations in all aspects of the system and in life in general. I was intrigued, but to be sure, I had no idea what a research project in sociology could look like. To be honest, I didn't really understand what a research question was or what a suitable topic would be. What do people study? I had no idea. But there was something there, right? Something in the space that Professor Lee opened for me as an undergraduate student. I visited him in office hours. He would recommend books. And over the course of the full academic year, I developed a proposal, learned a little bit about theory, collected some data, and wrote a report. A little study about attitudes towards censorship of so-called deviant music. I'm sharing this story, which is hopefully not a navel-gazing, look how brave I was as a student kind of story, but a look what an amazing mentor offered me story. Looking back, I'm struck by the time and effort that John invested in me. I was just an undergraduate student. He had 300 of us in just that one class. And this was 1995. Email was just starting to get used. And John hand-wrote comments on my memos and drafts, talking through ideas in office hours. He generally liked being a professor teaching students, and he invested in me. And in many ways, he showed me how to nurture and build an academic relationship. In the end, he guided me to graduate school in England, where he had gone in the 1960s. I've been lucky to have several John in my life. Another was Professor Ian Parker, a Marxist who taught us the history of economic thought. Somehow, he guided a group of undergraduates through the reading the primary theories in economics. Marx, Adam Smith, David Ricardo, John Stuart Mill, the actual primary tests, really, really hard stuff. He was the first professor that I had that had a line of students waiting to see him in office hours. It's hard to imagine in these days of emails, but Ian Parker had kids lined up waiting to see him in the hallway every week. He had to show up early to get a spot. On one level, there was nothing magical about this. You went into his office, sat in a chair, he sat behind a desk, and you talked about the work. Regular stuff. But again, there was something in the space that he created, right? Something in that interaction that he nurtured. The time invested in helping an undergraduate student develop an argument about material they could barely grasp. I remember him not because he was necessarily the most brilliant faculty member in the department. Maybe he was, maybe he wasn't, I have no idea. I just remember him as a kind person, right? Who made time for me and was generous with the time. Like John Lee, Ian Parker gave me a model for how to engage with others in collective work, despite how busy we might be. And the last professor I want to mention is Andrew Barry, another economist, but this time not for a personal reflection, but for an intellectual turning point. It was in one of his classes that I first encountered the Genie coefficient, and it was love at first sight. And so here I'm going to switch to the PowerPoint part of the talk. So if you don't know about Genie coefficients, you're going to learn about them today. For me, this is a beautiful thing, and it was one of the first intellectual things that really drew me to research, and I've used these throughout my career. It's an elegant way of measuring inequality, of starting to tell stories about social justice. Excuse me. Along the x-axis, along the bottom, you have the cumulative percentage of the population, right? From 0% of the population, the poorest 20, the poorest 40, the poorest 60, eventually everybody. And along the y-axis, you have our cumulative percentage of income, from 0 to 100% of the income in that place. Now, if income was perfectly equally distributed in a society, there would be a one-to-one relationship, and our income distribution would follow this line of equality. The poorest 20% would get 20% of the income, the poorest 40 would get 40% of the income, and so on. But of course, that's not what we have in real life. What we have are things like this, called the Lorenz curve. In this case, the poorest 20% of this population earn about 5% of the income, the poorest 40 make about 10, and the poorest 50 make about 15% of the income. What's beautiful about this, what's elegant about this, is that we can then quantify this distribution of income as area A, which is the area between the line of equality and the Lorenz curve, over area A plus B. If the Lorenz curve gets squished against the line of equality, that society is more equal in its distribution of income. Area A becomes small, it approaches 0. Or it could get pulled further away like it is in the United States. The Lorenz curve is pulled further away and the Gini coefficient will rise. Again, area A over A plus B. What's elegant about this, and one of the things that really drew me to this kind of research, is that this is generalizable to other things. So we can have what's called an illness concentration curve. Here we're not distributing income, but we're distributing something horrible. We're looking at infant mortality. We still have the population along the x-axis, from the poorest to the richest, and the y-axis distribute infant deaths. If things were equal, the poorest 20% of households would experience 20% of infant mortality. But of course, that's not what we have. We have very unequal distributions of mortality and disease. In this case, the poorest 20% of households experience just shy of 60% of the infant deaths in that society. And again, we can begin to quantify that relationship by the size of area A over A plus B. Tools like the Gini coefficient and the illness concentration curve have been central in my work ever since. But at the time, like many other students, I graduated with my degree, but without a real plan of where to go next. To be sure, Toronto did not have the great advising that we have at DePaul. In fact, I don't think I had an advisor at any point as an undergraduate. Maybe I was waiting to see if the get a job at the bank with an economics degree plan would work out. And maybe in an alternate universe, that's what I'm doing. But in this universe, I got a research assistant job at Health Promotion Research and met another great mentor in my life, Dr. Robert Combs. Health Promotion Research was a small consulting company run out of Dr. Combs' basement. We had little money and hardly any staff. Most of the time, it was just me and him. It was a skeleton crew. We did contract research for Canadian pharmaceutical companies who wanted to better understand patterns of prescription medication noncompliance. Well, the truth is they wanted to sell more product and get more doctors to switch to their medications. But I'll leave that part of the story for a different time. What I did get from health promotion research, however, was something very valuable, an appreciation for thinking about health at the level of populations, not just as a personal trouble, something within the biography of the individual, but as a public issue, something affected by society. It was here that I started reading widely in public health and came across the work of Richard Wilkinson, a social epidemiologist with an intriguing hypothesis. And this book really changed my life. I tell this to students all the time, and I hope that they get lucky in that and find a book that will change their life as well. Wilkinson laid out a very simple, very elegant hypothesis that linked income distribution and things like the Genie coefficient with life expectancy. Right? He asserted and built a great theoretical and empirical body of work to draw the connections between those two concepts. So with Wilkinson's book firmly in my mind, I knew what kind of research I wanted to do, right? It was public health, it was social epidemiology, it was then kind of sociology informed by medicine. With John Lee's support and Robert Gomes's guidance, I set forth for the University of Essex and life in the United Kingdom, a big new adventure. There I worked under Joan Busfield, Tim Liao, and David Pevlin, and with a group of fantastic fellow graduate students. I'm still struck that I was treated as an independent thinker from day one at Essex. I developed some skills with data analysis and a technique called multi-level regression, and explored the Wilkinson hypothesis, first with the British Household Panel Survey for my MA, and then for my doctorate, turned my eye to my home country of Argentina, using more sophisticated techniques and a new survey that Argentina had just made public. So this was the 2002-2005 period. Argentina experienced profound economic and political distress. The economy collapsed, and at one point we went through 5 presidents in a matter of 2 weeks. I was already interested in the relationship between social inequality and population health, and I wanted to apply the hypothesis to my home country. I want to point out this was without Wilkinson's blessing. Wilkinson's book and all of the literature that he developed was primarily extensively focused on the advanced industrialized countries of the world. He didn't think that it fit Latin America. He didn't think that it fit other parts of the world outside of the OECD. So it was a great kind of pressure point or interest point to try to pull the hypothesis, right, in a different format. So we built up a theory about the possible causes or links between income inequality and population health. And that generated my first big set of articles in Health Sociology Review, in Public Health, and still to this day, my most widely cited paper in the Journal of Epidemiology and Community Health. Along the way, I taught a lot, from first-year sociology tutorials to a stint as a teaching assistant at the London School of Hygiene and Tropical Medicine, and learned as much as I could about empirical research, particularly through a position as coordinator of a local research support group for the National Health Service, in many ways foreshadowing the collaboration that I would go on to have with medical doctors throughout my career. My first faculty position was at Simon Fraser University in a joint sociology anthropology department. My work grew in scope. I reached out to the Ministry of Health in Buenos Aires and started a relationship that continues to this day. This is the Ministry of Health building in downtown Buenos Aires. The bottom half of the building is the Ministry of Labor and Social Development. The top half of the building is the Ministry of Health. As you can imagine, every day there was a protest, either for or against something that was happening inside of that building. So it was a very interesting place to work. And they welcomed me. I got to visit there, I think about 5 or 6 times for month-long stints. I wanted to make sure that my work had practical value for people, right? And the best way to ensure that, maybe the only way to ensure that, was to collaborate and offer myself to others. As I look back, the brightest spots in my work have been marked by collaboration with public health professionals, epidemiologists, and medical doctors who had a population focus. A big lesson that I learned here was to reach out and offer yourself, offer your time, just like John Lee and Ian Parker had done to me, and bring something to the table, right? Don't just take. One of my main collaborators at the Ministry of Health, Bruno Lenetsky, who continues to be a good friend to this day, one day told me, and I was very proud of this, one day told me, Fernando, a lot of people come to us, email us, asking for data. We never see them. You were the first one to actually come and sit at our table and stay with us and work with us on this analysis. And I knew when he said that I was on the right track. And we did, I think, good work. We published a lot. We had taken a cue from their priorities. We focused on chronic diseases and risk factors for chronic diseases and inequalities in that. Publishing work in population health metrics, International Journal of Public Health, my first Spanish publication at the time in the Revista Argentina de Salud Pública, and more. At that time, we also expanded the work to the neighboring countries in the Southern Cone of Brazil, Chile, Uruguay, and Paraguay. And I had the great privilege and honor to work with a very diverse team of public health and epidemiologists from those countries under the support of the Pan American Health Organization. The big lesson here was how data could hold people together, how data and data analysis could bridge a lot of divides and actually bring folks together for a common cause. Again, publications were key in that era as well. And I published my second book called Global Health Inequities. One of the other building blocks that I had in that time period was involvement with the Canadian Coalition for Global Health Research. And I met two fantastic colleagues, two sociologists in Buenos Aires, Ignacio Chauvet and Graciela Dinardi. Our focus here, again, I took the cue from them in terms of what the priority would be. I brought tools of data analysis and a focus on social inequality, but they chose the health outcome. And for them, it was Chagas disease. I guess one of the things that I can claim as an achievement is that there are now hundreds of DePaul graduates who are walking around Chicago and other cities with some knowledge of Chagas disease. And otherwise, without my class, they would not know what this is. And you might not know either. So let me tell you just a little bit about it and why it's so interesting. I think one of my best papers, one of the ones that I'm most proud of, is this one, Chagas disease in non-endemic countries, sick immigrant phobia or a public health concern. Chagas disease, again, if it's okay if you don't know this, but it's one of the world's most important diseases of poverty, a neglected tropical disease. The bug on the top left is called the vinchuca. It goes under different names in different Latin American countries. In its digestive system, it carries a parasite, Trypanosoma cruzi, this little parasite in the middle. The bug is like a cockroach. It strikes at night, biting near the eyes or the mouth, and has the nickname of the kissing bug. When it bites you, it defecates into the wound and transmits that parasite into your bloodstream. Right? The short-term effects are inflammation of the bite wound, fever, some pain, and then over time, about 10 to 30% of people develop complications, cardiovascular and gastrointestinal. It is entirely associated with poverty, right? You have to live in very, very poor conditions to be susceptible. We have really good data on where Chagas disease exists, right? The burden it inflicts on primarily peasant rural populations in Latin America. And around the time, one of the things that really grew my interest is this second map here that didn't plot the distribution of suffering, didn't plot the distribution of deaths. And about 14,000 people per year die of Chagas disease. But at the time, there was an analysis that tried to predict the number of people like me, immigrants, who carry Chagas disease in our blood and could possibly contaminate blood systems in the north. Around the time, Peter Hotez, who I generally like, he's one of the big names in global health. You might see him on TV these days. He's one of the common interviewees on CNN in particular with respect to COVID. He's really, really thoughtful. But around the time, he did something that I thought was very irresponsible. He published this analysis called Chagas disease, the new HIV/AIDS of the Americas. To be clear, Chagas is not transmitted like HIV. It is not transmitted sexually, but it does pass from the mother to the fetus, or it can pass from the mother to the fetus, and it can pass through blood donations. As you might expect, Fox News got wind of this and raised all kinds of alarms. Poor Megyn Kelly was very scared. We are hearing reports today of a new medical mystery. That wasn't true. We've known about Chagas disease for 100 years. Some scientists are calling the new AIDS of the Americas. It can be fatal, and researchers are now saying it is spreading at an alarming rate, becoming much more prevalent in this country, the United States, which is a frightening scenario. So we had a real issue with this, right? Do conditions like Chagas disease matter just because they are a threat, that they are that they migrate and can cross borders? Or do we care about conditions because they afflict people, right? They cause unnecessary suffering. And that was the bulk of that Chagas work, trying to refocus, right, our lens towards health and human rights, social inequality, and not seeing disease as a threat. This brought me really to the work of Paul Farmer, who along with Wilkinson has been one of the big intellectual kind of pillars of my work. Paul Farmer I've described as the ethnographic counterpoint of Wilkinson. Both led me to explore the relationships between inequality and health, but while Wilkinson led me to statistical analysis, Farmer led me to historically deep and geographically broad analysis, and most crucially, this concept of structural violence, which has been so important to me over time. Right? Social arrangements that put populations in harm's way. The arrangements are structural as they are embedded in the political and economic organization of our social world. They are violent because they cause injury to people. And that violence is premature death. It's low birth weight, it's infant mortality, it's cancer and diabetes. It's any of the health outcomes that we study today. So I came to DePaul in 2010 and found a fantastic home in the Department of Sociology and in the Masters of Public Health program. And I came to another big branch in my work. I found it impossible to live in Chicago without engaging with local work. It hadn't been my intention. I was not going to focus on US health inequities, but you can't live in the city without recognizing the substantial, significant, tremendous inequalities that we have. I soon came across the work of the Sina Urban Health Institute, and largely out of luck, met David Ansel, who was then the chief medical officer at Rush University Medical Center. Soon thereafter, a group of us, including Ross Shaw and John Mazzio, launched the Center for Community Health Equity. And this, to date, has been one of the biggest achievements of my career. I think we've done really good work in the center. One of the most important papers that we wrote was this one here, looking at segregation and low birth weight, comparing community level data from Chicago and one of my home cities of Toronto. I think the data are quite striking. This is our map. There are 77 community areas. Low birth weight, to be sure, is not a disease in and of itself, but it's a marker, right? It's a marker for many other things. And we can take it as a sensitive indicator of population health. First, notice the remarkable range within our city. Our best off communities have as good outcomes as anywhere in the world, with a low birth weight prevalence of about 3.5. Our worst off communities, North Lawndale and Austin, have a low birth weight prevalence close to 20. Right? Tremendous differences just a few miles away from one another. This is what the Toronto map looks like. We applied the same scale that we have in Chicago to the Toronto communities. Apples and oranges, different healthcare systems, different welfare systems. That was kind of the point, to see how different things could be. There's 140 neighborhoods rather than 77, and that's, to me, okay. The remarkable thing is that the map is roughly one color, right? That's what health equity looks like. It turns out the best off communities in Toronto are exactly the same as the best off communities in Chicago. The worst off Toronto communities are on par with our average communities. So they've effectively chopped off the bottom half of our low birth weight distribution, right? Genes are not different in Canada, right? This is entirely the product of structural and social determinants. Through that work, we came into communication with Representative Mary Flowers, who invited us to come to her office to speak about the research and eventually to testify in a committee hearing that she chaired, developing a task force to tackle inequities in maternal and infant mortality inequities in the state of Illinois. For me, the link between health and politics is vital, right? And between research and activism is vital. We do this work not just to describe inequities, but to work in collaboration with others to change, right? To make the world a fairer place. Other work that we've done is expand that city analysis to look at Boston, Philadelphia, and Baltimore. And I have great interest in expanding that even further, looking at communities within these cities, right? What lessons could North Lawndale and Austin learn from similarly marginalized communities in Philadelphia and Boston? I think there's great potential there. We've done analysis of what's called the index of concentration of the extremes and its link with premature mortality in Chicago. One of the papers that I'm most happy with and proud of is this one looking at the concept of structural violence. and how the idea has changed over time as applied in health research. And then recently we published a piece in the New England Journal of Medicine looking at the concept of structural racism through the experience of one woman in the South Side of Chicago. Probably the largest product that we've published through the center is this book, Community Health Equity Chicago Reader, where we took the kind of a bold idea of trying to synthesize a complex literature going back to 1901, which was the first study that we found, and assemble it into one volume that could tell a story of how health equity work has changed in our city over time. To be sure, there's lots of science in it. There's lots of analysis and regression and quantitative analysis. But maybe the most interesting part of the book are the bits of activism. One of the golden pieces is this letter from the Medical Committee for Human Rights, which use statistics, which use data analysis to call out and denounce segregation in Chicago hospitals after the passage of the Civil Rights Act. Quentin Young wrote that letter partly based on earlier work from a pamphlet, again from a committee of doctors who use statistics and data analysis to identify and name racism within the healthcare system. They published a pamphlet called What Color Are Your Germs? I'm really proud that we found that and have been able to recirculate that pamphlet to a larger audience. And in the book, we also acknowledge the great work of the Black Panthers, right, who ran sickle cell screening and treatment programs in the city of Chicago when the city itself would not do so. The book and health equity work in general, maybe why I'm so passionate and interested in this work, is not just about number crunching, right? It's about engaging with activism. It's about engaging with social movements who are actively trying to make the world a better place. So this is an important protest a few years ago here in Chicago, calling for the University of Chicago to reopen its adult trauma center that it had closed many years ago, recognizing that the death of Damian Turner, a young man who was shot in the South Side and died en route to Northwestern, maybe would not have happened, right, if we had healthcare services where they were most vitally needed in our city. Another part of the book and another part of another key element of my work, I think, is thinking about communication and narratives and stories that we tell about health equity. This was a billboard that I saw while driving to Rush University Medical Center one day. A well-intentioned but hugely problematic public health campaign from our public health department, from the Chicago Department of Public Health. Can you imagine an African-American baby, a Black baby, I am an outbreak? And the anguish, right? The feelings of a community member who went out to get a can of spray paint to write beautiful on top. There's a huge history in this research that we're trying to combat about blaming communities for their suffering, right? To be sure, we are not looking at genetic differences. We are not looking at racial differences. We're looking at the health effects of segregation, of inequality, and structural violence. Your zip code, it all comes down to this. Your zip code shouldn't predict how long you live, but it does. It does in Chicago with remarkable accuracy, right? And a 16-year gap between the West Side and the Loop. And Chicago's not unique. Other US cities have this as well. We are one of the worst off cities in terms of health inequities, but it's something that happens throughout the United States. To a lesser extent in other countries, the Canadian data show that. Very different things are possible even within a capitalist system. And in this past year, the latest twist in my career has been to join this fantastic team at the American Medical Association, which has established a new Center for Health Equity. Here it's a tremendous challenge, right? Not just speaking to public health and not just speaking to social sciences, but to building up the capacity of physicians in the healthcare system, equipping them with the consciousness, tools, and resources to confront inequities, to name racism as a public health crisis, and then do something about it, right? Pushing the healthcare system upstream, not just looking at individuals, but looking at social and structural conditions. So a few lessons learned from all of this. My career has really revolved around a few very simple ideas. One is that health and social justice are inextricably intertwined. There is a deep connection between social inequality and population health. That's certainly not a new observation. Rudolf Virchow taught us that in the 1840s. Frederick Engels did as well. Yet the message takes on a different and arguably even more urgent meaning now, in the light of the awesome capacity of the healthcare system today. More than ever before, we must recognize that a great deal of suffering, preventable morbidity, and premature mortality is an injustice. Right? It is an injustice that hundreds of thousands of people still die every day or every year from tuberculosis. That death toll does not make our news, right? And we've had medication against tuberculosis for more than 40 years, yet hundreds of thousands of people still die of that every year. This, to me and to many others, signals the importance of the structural and social determinants of health. Similarly, it is an injustice that there is a 16-year life expectancy gap between the Loop and the west side of Chicago, just a few miles away. A threefold difference in infant mortality among our community areas. And it doesn't have to be that way. These patterns are the product of a system that intends to advantage some and disadvantage others. Bless you. Sorry, my daughter's beside me here. The second basic but very foundational idea in all of this is that the global and the local both matter. And many of us come to that realization, right, through whatever area of work that we have. In the end, I concluded that Wilkinson was wrong to only look at the advanced industrialized countries. He missed the worst of it, right? If we think of inequality in a global sense, he missed the worst of it. And the global doesn't just matter when the disease in question can travel across borders. Yes, of course, COVID is our top priority now, but diseases that do not travel must also be our concern. Chagas is important, even if it doesn't spread in the same way as other communicable diseases. It doesn't need to be rebranded as HIV for it to matter to us. If we are serious about health equity, we cannot ignore diseases that affect only the poorest of the poor. Third, very basic but vital element in all of this is that research and data are vital components of a critical social science. All of my work has been guided by the idea of radical statistics, that we can pursue statistical analysis in an objective way. Right? If I run an analysis and you run an analysis, we'll come up to the same answer if we're doing it right. But we do not have to be detached from our work. Our politics shape the research questions that we choose to study, the data that we choose to use, the variables that we choose to analyze, and the partnerships that we choose to nurture and develop over time. And the last basic but important point is the idea of collaboration, right? None of this really would have been possible without collaboration and an approach to collaboration with a sense of generosity and humility. So as I finish my talk, which for me has been an enjoyable review of my big ideas of my career, and I hope it's been enjoyable to you, I do come crashing back to our present reality. Over 200,000 people have died of COVID in the United States. As of today, 149,000 people have died in Brazil. That number does not regularly make any of our news, but it should. The data are clear that marginalized and minoritized communities have carried the greatest burden in both infections and in deaths. And we have a long way to go. Our national response is hampered by the administration's push to withdraw from the World Health Organization and its brazen denial of science. There is much to be done to connect medicine and public health systems and strengthen public health systems around the country. There's much to be done to even raise the discourse of health as a human right in this country. But at the same time, there's a note of optimism, right? It's remarkable. Institutions across the United States are declaring racism a public health crisis. And more people are coming to believe that it would be unethical to continue business as usual. In the end, I wonder, as many of you do as well, what it will take to make health equity a reality in our world. And I remain grateful to work with you all in an effort to make that happen. Thank you for your time. I look forward to your questions or devastating critique, whatever you have to offer.
Thank you.
Thank you. Thank you.
Thank you, Fernando. Bravo.
Gracias.
And Fernando has agreed to perhaps answer a couple of questions. So I don't know if we have any questions on the queue.
None that I've seen on the chat.
Oh, great.
But plenty of congratulations.
Thank you.
Thank you.
This gives me a chance to scroll through some of the Zoom tiles, and I'm so overwhelmed to see all these fantastic names and faces. And thank you for being here.
Thank you. And you know, as usual, after this, we always got the opportunity to walk into the pit and have a drink, some food, and continue to talk about the lecture. And that will happen. As I think that next time we are all together, we will certainly raise a glass of whatever is our choice to remember this lecture. And I have to thank you for, as always, provide not only awareness and understanding, as you know, everyone in academia does, but also show us a way in which we can act in a very DePaul way. So thank you so much, Fernando.
Thank you. Thank you. Thank you.
Before people leave, I cannot hesitate to remark about my young colleague here who has given us a remarkable discussion. Remarkable. And if it's not inspirational to all of us, it should be. Fernando,
Thank you. Thank you.
you know, I always say you're a bad brother, and you certainly proved it today. Thank you so much
Thank you,
for
Michael.
your
Thank you.
discussion with us. Thank you.
Thank you. Thank you.
Here, 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 here.
I'm unmuting to congratulate.
Thank you, everybody.
The chat line is just filled. You should read it, Fernando, including one that says, "Nice job, Dad."
That's a keeper.
That's awesome.
I did want to ask a question. If I could ask a question, do we have time for a question?
Mm-hmm.
Okay, great. I just wanted to get your perspective now that you've kind of had some time with the AMA and have this different point of view on the question of public health from that point of view. I just wondered what has struck you about this current moment and what it may be crystallizing. Are you seeing some promising avenues that give us encouragement about the ways that people are considering collaborating now, because states and local areas have had to really fall back on their own resources in ways that we wish wasn't the case?
Yeah, Margaret, thanks for that. That's a great question. And maybe that is a note of optimism in all this, right? All systems have been frayed to their capacity, and everyone is trying to figure out how to collaborate and how to draw on resources that they don't have control over. We're recognizing weaknesses and blind spots, things that we should have had in place that we didn't have in place. Like even just the basic collection of race and ethnicity in all aspects of the healthcare system. That's such a blind spot. Without those kinds of data, we're just glossing over the worst of the problems, right? And I think more and more institutions are recognizing that we can't go back, that things will get better, at least at that level in the future. And I'm very optimistic for that.
Fernando, we did have a question about whether do you have any stats on the disparities with COVID in Chicago?
Yeah. The damage has been great, right? April, May, and June were really, really tough months in the city, and the death toll was borne predominantly by Black and Brown communities. We're seeing a lot of improvement over time. The inequities are starting to come down. The very first wave of results that caused, I think, a legitimate amount of alarm was that 70% of deaths in the city were for Black people. The latest data is it's 43. It's still disproportionate to the population. It's still an inequity, something that's avoidable, unnecessary, and unjust. But it is better than that first snapshot of data, and that's reason to celebrate. Yeah.
Thank you.
Sure.
All right. Any final one question? Are we ready to wrap up for the day and go get that glass and still remember the lecture and enjoy the rest of the afternoon? So on that note, let me kind of finish up again, thanking Fernando for this wonderful lecture and thanking you for all you do for all of us, bringing light into such important subjects, and invite everyone to have a wonderful weekend. Hopefully weather will be helping to do that. And thank you for all you do and continue to do every day here at DePaul. So thank you so much. Have a wonderful weekend. And thank you for coming.
Thank you all. Good night.
Bye-bye.